Thanks, Sajid. All right, well, I'll try to thread the needle between two excellent talks here, and I think we'll emphasize a lot of the same points that have been made. These are my disclosures. Clearly, calcium is here to stay, and we're going to see this continue to challenge and vex our endovascular practice as diabetes and our population age. The anatomy of intravascular calcification, and I think as we learn more about using IVUS, is really important. Certainly there's a spectrum of calcification within vessels that can be detected as young as patients in their 20s and 30s in the femoropopliteal segment, but prevalence really increases after age 40 and then is associated with older age, diabetes, dyslipidemia, and a high BMI. But aging being the dominant factor for femoropopliteal artery calcification is well established, and that high calcium score is associated with loss of patency and clinically driven TLR. We, in many of our studies, use the Park classification to classify, and I think it's just helpful to keep in mind that this definition uses both the degree of calcium on one or both sides of the vessel, as well as the length of the lesion being calcified to help define the degree of calcification. So just a case very similar to the case Dr. Zeller presented of a patient who's undergone a prior femoral endarterectomy with a long chronic occlusion in the SFA. Trying to go back here. You can see that the reconstitution is within probably the P3 segment of the popliteal artery below the knee. And there is reconstitution distally through profunda and geniculate collaterals. So a very long lesion and very difficult to see the runoff in this particular case. So in this case, as many times is often needed, we start with an adequately sized antegrade sheet, then use retrograde access to shorten our base of operation, which is what we did in this case, where we got as far as we could go antegrade, and then used retrograde access to obtain a shortened base of operation. But still, this calcium can be very treacherous and difficult to work through, and often requires a number of different devices to make the connection from top and bottom. In this particular case, we were able to cross the lesion after some difficulty with the majority of the lesion dilating. There was one focal, particularly heavily calcified lesion, which can often be the case where, depending where you cross, if you get into a very tough nugget, then it can really create problems where even if you have the externalized wire, the equipment has difficulty getting through and crossing, in which case atherectomy is often needed. The challenge becomes, however, if you bend the wire, as I did in this case, you're really hosed. And so this was kind of a bailout case in one of my first cases where I really became a believer in IVL. So I was able to get through this lesion with a 1.2 balloon and extend a small channel through the lesion, and then eventually use IVL, and I'll show you the follow-up. But as Dr. Madashri just mentioned, the thickness and bulkness of calcium, the length, the characteristics of the femoropopliteal calcification are really important, and whether the lesion is stenotic or occlusive and calcified plaque and multi-level disease, particularly the runoff, is really important in the practicalities of treating these lesions. We have a number of lesions. I'm not going to go through these other than to say that sometimes, in fact, we do need more than one modality to get through, and the strategies to manage femoropopliteal calcification can include lithotripsy, high-pressure balloon, atherectomy, crack and pave approach, including rupturing the artery and inserting a stent graft, the Pierce technique to try to disrupt the intimal calcification externally. We have the detour device, and of course, there's hybrid approaches or femoropopliteal bypass. We've just looked at the reality study. I'll just note that it was a fairly large study as far as atherectomy studies go, a very complex population with 68% of patients with a high PAC score. And as has been mentioned, there was a 3% risk of perforations, 14% dissection rate, and 13% distal embolization. Provisional stenting was low, but despite all that, and despite how complex the population was, the freedom from TLR was actually quite good at a year, as was primary patency. And so I think this just speaks to how far we've come. Just to mention Disrupt PAD3, which of course was the randomized study of IVL versus angioplasty, followed by drug-coated balloon with 30 days, 1 and 2 year follow-up. It's been continued. The outcomes, as Dr. Garcia showed, were excellent at 1 and 2 years, despite the complexity of the calcified lesions in this randomized study. And I just put together this table on the right that shows that some of the key differences between the observational study, a different study looking at lithotripsy and orbital atherectomy. Of course, large numbers of patients in these observational studies, which is helpful. A variety of Rutherford classifications and treated segments, but I think the key takeaways are just the low rate of procedural complications relative to at least orbital atherectomies that was studied here, and of course it's lower than what we saw in reality. Hard to not mention Supera when we're talking about calcified femoropopliteal lesion being this interwoven nitinol scaffold that has fairly robust outcomes all the way out to 3 years, and certainly an important treatment for complex calcified femoropopliteal disease, and importantly, a very low rate of stent fractures. So back to the case, crossed with that 1.2 balloon, which allowed a channel for a S4 2.5 millimeter balloon, which I was able to use basically the entirety of the pulses on that one lesion, and then get an M5 6x60 in there and continue to dilate the lesion, which then allowed me to fully dilate the vessel and pass IVUS. We used a 6x200 balloon to pre-dilate, then a DCB, then overlapping 6.5 Superas up top, and then chocolate balloon angioplasty in the tibial-peroneal trunk. And you can see the runoff was good, and the remainder of the femoropopliteal segment turned out quite nice, and the infrapopliteal runoff was also preserved. So my algorithm for femoropopliteal calcification, of course, starts with guide wire crossing and angioplasty. I too heavily use IVUS in just about 100% of cases. I feel like it allows me to see if I'm going to pull an atherectomy device where I really need to focus my attention. It's very difficult to treat these long femoropopliteal lesions with a device without having consequences, including the consequence we saw in reality and other studies. IVL versus atherectomy depends on a lot of the lesion characteristics, which this panel has discussed, but certainly delivering drug is important. Interwoven self-expanding stent is another important strategy. And then contingency planning for dissection, perforation, or inability to cross. So I think success with femoropopliteal calcified lesions takes the right skills and strategy, equipment, and understanding lesion morphology and where these tools facilitate best a successful procedure. So to conclude, complex calcified femoropopliteal disease will continue to present challenges for endovascular revascularization. Understanding calcified lesion characteristics it really helps guide my approach and prepare for and use consistent crossing and treatment algorithms for safe, efficient, and consistent calcified crossing and treatment. Thanks.